So before I begin, I'd just like to say that I'm speaking to you from Toronto, and that I'm standing on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and is now home to many diverse First Nations, Inuit, and Métis peoples. And I give that acknowledgement with a full heart. And I have many reasons for wanting to do it, but one of the reasons that I want to do it today is to remind myself that I'm telling the stories of people who sometimes don't have an opportunity to tell those stories for themselves. And you'll see in a moment just how pertinent that can be. Of course, we're here to talk about prostate cancer, and we know that prostate cancer is the #1 leading cause of cancer in men, and it's the 3rd leading cause of death in men. We know that it's important to start thinking about prostate cancer from the age of 50 onwards, to nudge your family doctor to get PSA testing and to heed the results of that PSA testing. The other thing that I want to be able to say, and you've already heard why, is that you're not alone. You have resources, and how you gather those resources. I'm going to talk a little bit about that through the power of teamwork. And no question that Prostate Cancer Foundation of BC is a major resource that can help you if you're just starting a support group, or if you have a well-established support group. I said I wanted to tell the stories of people who have difficulty telling their own stories, and I'm going to start with a personal story right now that frankly has nothing to do with prostate cancer, but I think you're going to pick up some threads that could relate to you, would certainly relate to Bob 20 years ago when he was a new prostate cancer survivor and was trying to join a support group and ended up forming one himself. So I'm telling you the story now about me and my sister. My sister is a few years older than me, and she was retiring in 2015. And I made it a point to have lunch with her on one of the last days that she was at work. And there's a photo of the two of us together. She took me on a tour of the place where she worked. She worked at a shelter for women who had experienced domestic violence. She was known far and wide as a wonderful counselor, an intuitive counselor, a listener, somebody who helped women who were discombobulated by having suffered domestic violence, often coming with young children and having to leave their homes, flee for their lives with nothing more than a small bag packed. And she was often the first person that they saw when they needed to get new housing, when they needed to look for work, when they needed social supports and other supports for their children, schools for their children, et cetera, et cetera. And she did it beautifully. She was one of the old time counselors, did it for more than 3 decades, did it in a way that she thought was right. She took care of clients and took care of them on a personal one-to-one basis, and was less concerned with process outcomes than she was making sure that she connected with them. And I'm sharing, I'm wondering if I can share change, I don't know if I'm able to change the percentage of the screen that is being taken up. The reason why I want to be able to do that is that I'm seeing everybody's faces on the side. Oh, I can move it to the side. Okay, that's good. As long as I can move it, I'm great. Fantastic. There. Now. So, I told you about my sister. In 2019, life threw me a curveball. My sister was diagnosed with young onset dementia, and that by definition is an onset before the age of 65. She's currently 69. And the first inkling that I was given came not from me or my personal observations. I might have had a clue or two, but as a brother, I was probably suffering from denial and didn't want to see what was in front of me. It was my sister's friends who contacted me with text messages and phone calls and voicemails saying that they were concerned that my sister was not acting right, that she was, ordinarily had an encyclopedic knowledge of people's names and was forgetting names and forgetting situations. And there were 2 or 3 severe episodes when she was out with them at one of their friends' homes, playing cards, playing games, and got totally confused and very sleepy. And on one of those occasions, in fact, she had to be brought to the hospital because they thought she was having a seizure. And I thought she was having a seizure. And all the epilepsy and stroke workups were negative. And the internist who saw her and the neurologist who saw her whispered in my ear that she probably had dementia. And you can imagine what a blow that was to me. So I became more and more involved in her life. And, that was not my intention in the first place. I wanted to be able to lean on my brother-in-law, but there was something odd about my brother-in-law and the way he was acting. The night that she was taken to the hospital, he needed me to tell him how to get to the hospital, that we all knew where it was. And anybody who grew up in the Toronto area, it was Sunnybrook. We all would have known how to get there. It backs onto Edwards Gardens and Sunnybrook Park. And it's a place that everybody knows how to get to in the city. So I filed that away as something that was curious. And then when my brother-in-law followed the ambulance and drove to the hospital, he had to go to the pay parking lot. And he called me again to ask what he was supposed to do and how he was supposed to gain entrance to the car park, push the button, get the ticket, etc. So I certainly paid attention to that. A few months later, I started getting phone calls from my sister and brother-in-law's financial planners saying that they were concerned that there were some unusual transfers of funds and that I should look into it. In fact, I was listed on their file as a trusted contact, and with their permission, I became involved. And one thing leads to another. You may be suspecting what I'm going to say. My brother-in-law, her husband, was also showing signs of dementia. They have a son, and their 27-year-old son, who they adopted from an orphanage in Eastern Europe, has unspecified cognitive and emotional issues, possibly fetal alcohol spectrum disorder, although he has never been formally diagnosed. So this is quite a situation. This isn't just my sister at risk. This is an entire family at risk. And one night, my wife and I came to their home and we looked through some of their papers with their permission, and I saw a power of attorney document. And the power of attorney document was for both personal care and for property. And it listed me, I discovered, as the alternate power of attorney, both for personal care and for property, for both my brother-in-law and my sister. They had named the opposite spouse as the actual power of attorney. Now, if you know anything about case law, you know that being an alternate power of attorney is powerless. You're not the actual power of attorney until and unless the actual power of attorney either resigns or is proven to be incapable of functioning in that role. You might suspect that would happen, but when it comes to personal care, the healthcare system needs a decider. And when they found that the partner couldn't function as the power of attorney, they came to me quite readily and were quite happy to have me as the power of attorney because I'm a physician and they need decisions to be made. When your life is hanging in the balance, when you have to decide, do you get a hip replacement or not, you need someone to say yes or no. When it comes to property, however, they tend to kick the can down the road. Financial institutions would rather be absolutely certain that you need to be the power of attorney because they're terrified of fraud. They are afraid that somebody's going to step in and claim to be the power of attorney and drain the life savings of that person. That's their orientation. But you can see the kind of situation that I was involved in. My sister's friends were begging me to get more involved. I could see that my sister could no longer speak. She was having mobility issues. She was living in a home with a partner who was becoming increasingly incapable of looking after her. So you wouldn't be, at that moment when the financial issues became apparent, when it became apparent that they weren't managing their money well, that they were making transfers of funds to pay for things that were dubious value, certainly not helping with care, and were likely draining their life savings, I tried to step in, and my brother-in-law fought me at every step along the way. And in fact, at one point he said, Brian, you're dead to me. So that was the kind of situation that I was in. I still had to try to look after my sister. So that's what she looks like today. And in fact, most recently she was in hospital with severe aspiration pneumonia. She nearly died, but miraculously she did okay. She's now back at the long-term care facility. I have since been installed as both the power of attorney for personal care and for property. But it took a long fight. I had to get a guardianship lawyer. I had to go to court. Eventually, we had to get my brother-in-law to resign as power of attorney. You can imagine how many hours, when you think about the care issues, the financial issues, the legal and guardianship issues. So you wouldn't be surprised if I told you that I've had a rough ride in the last few years. A lot of sleepless nights, a lot of stress, and a lot of irritability. And I liken what happened to me to the situation that Bob was in 20 years ago. The situation all of you are in when you're beginning a cancer journey, when you are the spouse of somebody, the partner, the adult child of somebody who's in the midst of a cancer journey. It could also be having, an adult child in trouble with the law or being sued by your neighbor for some irregularities in the way you did your home renovations that are now having an adverse impact on them. It's a major issue. You can't just wave a magic wand and make it go away. You have to handle it. You don't know how to handle it, just as Bob didn't know the first thing about setting up a support group 20 years ago. And yet you have to kind of dive in, and you have to try to keep sense of yourself so that you don't kind of fall into a puddle of despair. And I invented some rules for how I was going to do this. First rule, figure out what you hate doing and find someone else to do it. And, if you're setting up a prostate cancer support group, maybe you aren't the visionary. So you get somebody else who's the visionary, or maybe you are the visionary, but you hate the plotting details. You're not the detail person. You're not the kind of person that remembers how you did it wrong 3 years ago and what you have to do to fix it. Or, what if you have trouble remembering passwords like me, and you have to keep changing them. Or, in the case of my sister, there are times when I don't mind spoon feeding her, and there are times when I don't like it. Maybe for one reason or another. So you need other resources, and you either hire them or you find volunteers, which of course you're doing. You've already heard that the vast majority of people who are members of this fine organization are volunteers. People who belong to prostate cancer support groups are almost by definition volunteers. There are very few paid staff. So you have to do that. That's the first rule. Figure out what you hate doing and find someone else to do it. Here's the second rule. For those of you who are perfectionists, and as a medical doctor, we tend to be perfectionists because we feel a great sense of shame when we're caught out making mistakes. I'm reminded of the saying by Voltaire. This is translated into English. Now, this is a situation where you can't say imperfection is not an option. You can't, because you don't know what you're doing as you're stepping into this situation. So you have to learn as you go. There's going to be a lot of trial and error. So at the end of the day, you ask yourself, as I ask myself, is my sister better off for my involvement? And if she is better off for my involvement, then I tell my perfectionistic side to shut up. Just stop it. And I will actually say, Brian, stop it. Your sister's better off, because there are days when that perfectionistic streak in me tends to bubble up, and I'm getting unhappy that I wasted money on this, or an example right now is, how do I get to a new normal with the fact that my sister now requires more care than the long-term care facility can provide, because it takes an hour to an hour and a half to feed her a meal, and they won't spend an hour and a half feeding her. They'll give her a few spoonfuls and then take the plate away, which is not good for her nutrition because she's lost weight because she can't feed herself. Perfection is the enemy of good. So in that case, I decide I'm going to spend a little extra money. My sister has the resources now that I have control of her finances, and I'm not going to worry about every dollar, because she needs to eat, and I also can't be her feeder. Being a power of attorney for property doesn't mean that I'm obliged to fill in every time that a personal support worker is unable to attend. Third rule, don't drown in other people's stuff. And, you know, I like to think that my sister would not want me to weep every time I see her. And there are times when I feel like doing that. And there are times when I look at the two photos, the before and after, that photo with me and her, and when at her office, and that photo afterwards, and I go, how the hell did this happen? But the important thing is that if you're going to be a good resource for other people or a good teammate, you can't drown in other people's sorrow. So that's another rule that I learned. Along the way, I learned rule number 4, which is what I want to talk about here. And that is to embrace the power of teamwork. And you're seeing some of the team members there that I've assembled over time. In the upper right, you see Rhonda and Janice, who were 2 of the dear old friends of my sister who kept contacting me, pulling me in more deeper and deeper into my sister's situation. Without them, I would not have known how she was doing. Without them, I would not have realized how much she was at risk in her own home because her husband was unable to look after her and her son was unable to assume the role as care partner. And so they were essential. They remain essential for social support today. And I'm trying to see if I can get them to feed her a few meals a week. Upper left, my partner Tamara, who feeds my sister 1 meal a week and visited her in the hospital. That's a photo of the 2 of them during her recent admission. The middle photo on the left-hand side, Christine. Christine is a PSW who became a nurse, and she was instrumental in the hospital when my sister was having life-threatening episodes of aspiration. She would choke, and I saw one of them. She nearly died. And it was great to have a nurse who was at the ready, who could be there at the bedside, who could alert the staff and could also do suction because her scope of practice enabled her to do suction. So you get the idea of this team. This is a matrix slide that just shows you all the team members. You don't need to know them all. Personal support workers, doctors, nurses, geriatricians, neurologists, day program supervisors, PSWs, disability services for my nephew, my sister's friends, my family, my children, and of course, to the extent that they're able to do so, my brother-in-law and my nephew. So I learned to embrace the power of teamwork. And Bob, I'm sure you embraced the power of teamwork 20 years ago when you were getting started, because what was one of the first things that you did? You didn't reinvent the wheel. You looked to other support groups for guidance and advice in the same way that the Prostate Cancer Foundation of BC wants you to look to them as a resource. So I'm going to ask you a question right now. I want you to reflect on your own experience. Are you part of a group or are you part of a team? And they're not the same. I know we all talk teamwork makes the dream work. This is a photo. These are a couple of photos that show you some of the team members that I work with in the emergency department. Now, you might think that we embraced teamwork from the day the first emergency department was constructed. I guess on some level we did, but I can tell you that my personal journey from me to we is only fairly recent. There was a time when I used to stride into the resuscitation room thinking, I alone am going to diagnose the problem. I alone am going to solve the problem. I have to know every drug dose. I have to know every procedure and how to operate every piece of equipment. And, lo and behold, something happened to the practice of medicine. It got way too complicated for me to know everything, to keep up with everything all the time. And yet I had this attitude that said, if I need to ask a nurse if it's okay to send a patient home, then I shouldn't be practicing here. And that's just wrong thinking. And I'll show you why in just a moment. But I can tell you that today, when I work in the emergency department, I do my best as an emerg physician when I work alongside a medical student, a resident, a charge nurse, a team leader, an area nurse, a social worker, registered dietitian, occupational therapist, physiotherapist, et cetera, et cetera. And we all give our views on how to manage the patient. When we do that, you get something called team cognition, and team cognition, in fact, is superior to anybody's individual point of view anybody's particular vision on how to solve a problem, how to work a problem, how to envision the development of a support group. And so you are part of a team if, here are some of the criteria. You are part of a team if team cohesion matters more than status, if team goals are more important than individual goals. That doesn't mean individual goals aren't important. For instance, I want to shine, I want to look good, I want to get good recommendations, I want rate my doctor to rate me highly, I want my patients to feel that I've heard them. I've got a lot of personal goals, but I'm also aware of team goals. You're part of a team if complaints, if observations that are sharp, that maybe nudge or tweak the status quo are welcomed and addressed. That new procedure that we have, that we've set up, for instance, going from Zoom to Microsoft Teams or from Microsoft Teams to Zoom, I've detected an issue with that I want to discuss with the team. Your complaints are welcomed and addressed. And if they aren't, you probably aren't. Your group is probably more a group than a team. Third, you feel safe making suggestions. You don't feel that you're going to be ostracized if you make those suggestions, singled out, criticized, maybe insulted. And I'll describe a situation when something like that occurs in a couple of minutes. You are part of a team if your suggestions are dealt with, either aired by the team, and if there's something to them, actioned. And then finally, you are part of a team if everybody volunteers to pitch in. If you are being overloaded with responsibilities, maybe you're planning a specific event, do other people step in to assist you because because the team matters? And if any one member of the team is having trouble because they're overloaded with responsibilities, then the responsibilities have to be balanced out. And do you feel comfortable accepting help from other people? I can tell you in medicine, that was a big stretch for me. There were moments when I felt as if I were accepting help, would that be a sign of weakness? And I can tell you early on in the pandemic, one of the first nights when we had no vaccine, no treatments that were evidence-based, and we had a disease that was lethal, apparently potentially lethal to anybody over the age of 60. I was coming in to do a night shift, and on the first night following the WHO's decision to call a pandemic, a colleague of mine, Dr. Paul Koblitz, was working the 9 p.m. shift. So he came on 2 hours before me. He pulled me aside and he said, "Brian, I'm going to stay here all night, and so I can do all your intubations for me in case we needed to put anybody on a ventilator." That was so that I wouldn't die of COVID. And I can tell you, for a moment, I was embarrassed. I thought he was thinking I can't intubate and then I'm weak somehow. And then afterwards, I kind of ducked into a room and I started to cry because I thought, wow, he would do that for me. Wow, he's a team member. He gets teamwork. And that's a really important part of teamwork. This is an example of another team. This is a medical team in Renfrew County, which is 7,500 square kilometers of some of the most austere and beautiful land in northeastern Ontario. It encompasses the Ottawa Valley. It encompasses Algonquin Park and all of Atomic Energy of Canada Limited plants, Chalk River, Deep River. It encompasses Canadian Forces Base Petawawa. It's a beautiful part of Canada. And it's also one of the most sparsely populated, where 1 in 5 people have no family doctor. There's no public transit, or very little. There's almost no urgent care clinics, which means anybody like Mary Louise Turner there, who needs emergency care, she's not going to get a house call so easily from a family doctor. And a lot of people don't have family doctors anyway, which means that if she has a problem, she's probably going to the emergency department either via 911 or by a family member who has to drive her there. Well, in this part of Canada, they have done something different. They have embraced the power of teamwork. And you have paramedics like Matt Cruchet in that slide and Matt Roussel in this slide. They're acting not as scoop and run emergency paramedics, but as something called community paramedics. They are people who are in specially equipped vehicles. They don't respond to emergencies. They respond at the behest of family doctors and nurse practitioners, and they go to the homes of people who need an assessment and don't necessarily need emergency care. They are the eyes and ears of family doctors and nurse practitioners, and they have an unusual skill set. They can treat people with IVs, they can do blood work, they can do point of care ultrasound, they can do x-rays, they can do other kinds of testing, EKGs, put people on monitors, do vital signs, and they communicate with a team. And that's the key. This isn't just a splashy initiative for community paramedics. What makes this community paramedical program work is that it embraces the power of teamwork. So you have community paramedics working with nurses, nurse practitioners, family doctors, PT, OT, RD, social work, etc., and pharmacists to provide care. And this was an initiative that's been going on for about 5 or 6 years, but it took off at the beginning of the pandemic when they created something called the Virtual Triage Assessment Center, which was a 1-800 number, a toll-free number that anybody in Renfrew could call, and they would be put in touch with a doctor, a nurse practitioner. They'd be attached to a practice, and they could be seen by a community paramedic if and when necessary. Paramedics have now expanded their toolkit to include palliative care. This is a real palliative care patient in a palliative care situation. They're moving into long-term care. The next thing they're going to do is to help provide nursing home type care in the homes of people who need it, so that they don't have to be transferred to a long-term care facility, or they could be managed as if they were in a long-term care facility while they're waiting for placement in a nursing home. It's an amazing initiative, and there are others that are going to come down the hopper as well. I want to talk to you about some of the stressors that have promoted the power of teamwork. You've probably heard a lot about emergency department closures right across the country, including BC and Ontario, Manitoba, Saskatchewan, and Atlantic Canada. And we are suffering from incredible stress right now, high volume, sick patients. There is a huge attrition rate among nurses who are fed up with low pay and lack of recognition. And, in many hospitals, they haven't been given the flexibility to go down from a full-time equivalent to maybe 0.5 or 0.6 or 0.7 because the hospital's making them choose between full-time work and quitting. And so some of them are quitting. And there are high rates of stress and moral injury and burnout, reduced staff. And as a result, we're getting temporary closures that are threatening the function of our emergency departments. And this is something as an emergency physician that I know quite well. Dr. Catherine Smart, who is the immediate past president of the Canadian Medical Association, has said that Canada's healthcare system is on the verge of collapse. And I can tell you that burnout rates in healthcare are through the roof right now. And some of the symptoms of burnout are exhaustion, lack of energy, sleep disorders, reduced performance, concentration and memory, reduced initiative. People who, instead of running to the resuscitation room, walk slowly and they're thinking, what's the use? Nothing that I do ever makes a difference. And rates of burnout among frontline staff are as high as 50%. One of the reasons why I want to talk about this is that burnout blocks empathy. And if you aren't empathic, you can't be kind to your patients, and you also can't practice teamwork. So I can tell you that there are some amazing proven benefits of teamwork in healthcare. The diagnosis is more accurate because more people have eyes on the problem. The treatment plan is more appropriate and more likely to be followed by the patient because it has been developed with everybody's eyes on the problem, so that everybody who potentially sees flies or flaws in the plan, flies in the ointment, are able to weigh in. And so the plan is adapted so that it takes those shortcomings into account. In business, it leads to greater productivity, higher profits, improved safety, lower absenteeism because people have more joy, they have less burnout in the work that they do. And there are some good neuroscientific reasons why teamwork is the way to go. This is two jugglers, and there have been some MRI studies of jugglers who work in a two-person team. The smallest team is a duo. They call it a duo in juggling. Neuroscientists call it a dyad. if you do functional MRIs of jugglers who have gotten into sync with one another, so that they are getting an MRI of their brains while they are looking at film footage of them or video footage of them juggling with one another when they're in flow, they find some amazing things. They find that cooperative jugglers share neural pathways that activate the same areas of their brain. At the same time, complementary or different neural pathways that complement each other are also activated. But very, very important when it comes to jugglers, the initial coordination cost, the cost of getting into sync with one another, has to be paid. Otherwise, they don't get into that wonderful state of flow when they're forgetting that they're juggling as two people. They feel like they're one person. And I know that, you know, in the emergency department, when we do an amazing resuscitation, it's quiet, it's calm, and people are getting into the flow with one another. Now, to achieve that, though, you have to pay the coordination cost. And that means you have to get to know one another. Two jugglers have to adjust. Maybe there's a more adept juggler and a novice. And so maybe the novice doesn't return the pins as readily or as accurately. And so the more experienced juggler moves position so that they can make the load a little bit easier for the novice juggler. This is called the coordination cost. And I can tell you that when it comes to the emergency department, we have a regular turnover of nurses and staff. And I have heard people say once in a while, it's not worth training the new people if they're going to leave in a month. So that might be one of the factors. A high turnover rate might be one of the reasons why people don't want to pay the coordination cost to get into sync with one another. But you must get into sync if you're going to achieve that state of flow where you're actually experiencing the joy of working with one another. As I said, everybody talks teamwork. Teamwork makes the dream work. We all know the slogans. I did a Google poll when my book, The Power of Teamwork, was published, and I did some surveys. And one of them found this, a very telling statistic. 56% of 1,000 respondents or more said that the company where they work talks a lot about teamwork, but doesn't follow through with meaningful actions. And I hear a lot of people say that. So what are some of the issues that get in the way of teamwork when it comes to medicine? Well, in healthcare, I've already told you the I alone attitude, the fear that needing help is a sign of weakness. There may be a bit of narcissism, people thinking it's my job, I'm supposed to show everybody that I know everything. Or it may be people who don't want to pay the coordination cost because they have a high turnover rate. In the school system, you know, I've done a lot of speeches for boards of education, and they say that the erosion of trust from vaccine and mask mandates has made people not trust the school system. Also, there are a lot of schools that have not upgraded ventilation and air filtration systems. And so they, you know, teachers going back to those schools rightfully fear that the school board doesn't have their back. Support groups, you know, maybe you've got one or two people that you rely on, one or two stalwarts, and you're not sure that everybody else is as engaged as they are. So you keep going back to the well with the same people, and that becomes a bit of a self-fulfilling prophecy. What about working from home? Most of us work from home unless you had an essential service, provided an essential service. And how much have our social skills been degraded while we worked from home? Do we have lack of familiarity with one another? To make a team function well, you have to know everybody's attributes, what they do well, what they need help on, so that you can rearrange the pieces so that you make people shine, so that you make the team function better because you put people into roles where they're more likely to succeed instead of fail. Because why do you do that? So they feel better, so that the team does better. And if you don't know the members of the team, you may not be able to do that. I'm going to ask you a question. All of you, if you're going to have support groups, you're going to have regular meetings. And this may be true of your support group meetings, or it may be true of other volunteer meetings, or perhaps places where you work if you're still working. Are your regular meetings the place where great ideas go to die? And, I can tell you, in my emergency department, our departmental meetings were often the place where great ideas went to die because there was a kind of a rigid command and control structure. There's a whole bunch of reasons why people, why leaders might want to grip tightly onto the agenda. They're afraid the meeting will spiral out of control, that it will become just a rant where people are going to be complaining. And there's going to be maybe they're afraid that if somebody gets up to speak, this person tends to have a negative attitude and tends to make other people feel negatively about the place. There are many, many reasons for that. There are some techniques that you can use to overcome those. And here we are. It was a little slow. So, one that I talk about in my book is an improv technique. And, I'm not going to teach you how to do comedy improv, but this is where it comes from, where it's an improv exercise. This is what they learn at comedy clubs, where two people stand on stage. The moderator gives them an absurd scenario that they have to expand upon. So it might be, for instance, the two of you are working, you're the maintenance employees on the first, on the toilet on the first international station on Mars. And once again, the toilet is not working. Go. And, or something as absurd as that. In the exercise, the first person riffs off of that scenario. The second person listens very, very carefully. And as soon as the first person finishes, the second person says yes, which means they agree with everything. They at least accept everything that the first person said. And then they say and they build upon it. And meanwhile, they build upon it. The first person's listening to everything the second person is saying. And as soon as the second person finishes, the first person says yes, and they go back and forth and back and forth. And they try that exercise. And the idea is twofold. First of all, you don't have to agree with everything the first person is saying, but you accept it. That's the first thing. It's a sign of respect. The second thing is you're listening to what they've said. I don't know about you, but there have been times in my life when I have, instead of listening to people talking at a meeting, I just sit patiently, quietly, with great discipline, waiting for the first moment when somebody stops speaking long enough for me to jump in. I'm not listening to a word that they're saying, and I'm just going to jump in with the thing I've been dying to say for the last 15 years. And that's not listening. That's my point in saying that. So this is a technique that you can try. You can also try yes, but, which means that if you play yes, but, you're going to accept what the first person says, but then come in with, we tried that last year and it didn't work. Or, the literature says that idea won't work, or something like that. And then the third thing that they try in this exercise is no. Just, that's a conversation stopper right away. So try yes, and you might find it works better. Here's another way of getting people into sync. And I'll show you what they do. You don't necessarily have to take people to an art gallery to do this. So the first thing that you do, so that the woman that you're seeing there standing up facing the group is Alexa Miller. She's an artist and she is a museum docent, which means that she takes people to museums to try to enhance their appreciation of art. In this case, she took a group of students who were first-year medical students to Harvard, and she took them to the nearby Museum of Fine Art, which is just steps from Harvard Yard, and she plunked them in front of a sculpture and asked them 3 questions. First question, what's going on in this picture? And these students know nothing about art. In fact, they're terrified of answering because all medical students are afraid of getting the wrong answer. There is no wrong answer. So the first person says, do we have, those are the 3 questions. I don't have them here. Okay, so first question, what's going on in this picture? It's a sculpture of 2 people in relation to one another. And the first person says, I think they're wrestling with one another. And she asks the second question, what do you see that makes you say that? That's the critical thinking bit. And then the third thing is, what more can we find? So she invites the rest of the group to give their view. And another person says, nah, I don't think they're wrestling. I think they're embracing one another. Oh, what do you see that makes you say that? What more can we find? And by doing that, slowly but surely, she's getting everybody in the room to feel safe to say what they see. And it's fascinating, at first everybody agrees that they're wrestling, and then everybody agrees that they're embracing one another. and then they go back and forth and back and forth. But the idea is that eventually they come to a much richer understanding of what they see, and they now appreciate everybody's opinion of what they see. You can take that approach and take it right to the bedside. You can use that approach, for instance, when you're in front of a patient. What do you see? What do you say that makes you say that? I see this patient in respiratory distress. What makes you say that? He's using his accessory muscles, or he's flaring his nostrils. He's breathing fast. He's got beads of sweat. And you can do it, of course, with permission of the patient. So you can do it at the bedside. You can also do it at a virtual meeting. And yes, it might be a bit more difficult on Zoom, but it's not impossible. The payoff of using this strategy, which is VTS, which stands for Visual Thinking Strategies, is that critical thinking is encouraged. It reduces premature closure and other cognitive errors. It encourages something called team cognition or team diagnosis, which it turns out is more accurate, better for the patient, and you make fewer mistakes if you trust the team instead of any one person trying to figure it all out by themselves. And also, very important, creates a safe space for everyone to say what they see, which is very important for that fledgling prostate cancer support group. If you're starting out and you want to start a new initiative, you want everybody to opine as to whether this initiative, this bake sale, or this run, this fun run, or whatever you want to do is going to work, or this new campaign, this merchandising campaign, marketing campaign, etc. You can also play games. And in The Power of Teamwork, I talk about a game called Friday Night at the ER. The point of this game is that in siloed hospitals where each department is trying to hoard resources and prevent themselves from being kind of either taken over or taken advantage of, so they say, by other departments, this game actually teaches you that the more you try to hoard your own resources, the more you do things like close off your department to new patients so that we can have a pause, so that we can catch our breath, the more you harm the other three departments. So it's a four-sided game where each manager plays the manager of either the emergency department, the step-down unit, the operating room, or the ICU. And what they learn in this game, which is framed as 24 hours in the life of the hospital, that what happens is that the more you cooperate with the other departments, the better the hospital runs. This game, which was developed for hospital personnel, is now being used by Fortune 500 companies, including the Disney Corporation, the CIA, and many groups in Canada. So you can play games. That's another way that you can, these are board games that can get you up to speed and on the same team. I want to talk about an incredible team leader, because leadership is really important when it comes to teamwork. Trevor Jane, that's Dr. Trevor Jane today. He oversaw the largest makeshift mortuary in recent history. He's a trauma and emergency physician in Prince Edward Island. He was awarded the Meritorious Service Medal, and he gets teamwork better than anybody I've ever met. And I want to tell you why. Back in 1999, Swissair 111, a terrible disaster in which 229 passengers and crew perished off of Peggy's Cove when their plane, which was bound, their Swissair flight that was bound for Geneva, crashed. What started as a rescue operation very quickly became a recovery operation. And it turns out that Trevor Jane was a member of the Canadian Armed Forces Reserve. He had been a commissioned officer, and he was in his fourth year of medical school. He had just started at Dalhousie, and he was contacted at about 3:45 in the morning. In fact, a knock on the door, an RCMP officer ordered him. He was being mobilized and ordered to Canadian Forces Base Shearwater, which was the closest forces base off of Peggy's Cove. And he walked into Hangar B, where he found chaos. Nobody knew what they were doing. He was a 28-year-old medical student who also had officer training. He was brought out of bed because he had pathology experience. He had volunteered with a pathologist at a hospital in the Annapolis Valley, then became an employee, a pathology assistant, so that he could earn some money to help pay his tuition. And he was the guy who knew how to set up a pathology suite, what you needed: a table, a drainage system, a source of water. And he got up on a pile of boxes and sketched out in that forces base one pathology suite and eventually 12 pathology suites. And he was instrumental in hiring staff and mobilizing them. And he was instrumental in the success of that group. They identified each and every member, each and every person who perished, all the crew, all the passengers. And he did it by listening to everyone on the team, especially those who were least advantaged. And, why did he do that? He did it because he was a BIPOC physician who, as a teenager, knew what it was like to be bullied, to not be listened to. Remember, I started my talk to speak about people who weren't being listened to and why it's important to do that. So I just want to tell you what a good team leader does. They don't answer every question. They don't bark the answer to every question, which is what physicians often do. We make the mistake in medicine thinking that the physician should be the leader in every case. No, the best leader should be the leader in every case. And a good team leader asks questions and gathers the wisdom of the group instead of barking out the orders. They delegate instead of taking on every task. They know every team member's superpower. This one's good at social relations. This one is really good when there's a conflict between two members of the team because they're the one person that everybody feels comfortable confiding in. Or they're the visionary, or they're the person who knows every rule, every procedural rule, knows how to get things done, et cetera, et cetera. Or they're the expert on prostate cancer, or they're the expert on this particular treatment or this particular herbal remedy or whatever. The other thing that a good leader does is they encourage the team to work to their potential and doesn't throw them under the bus when they make mistakes. Also very, very important. Now, we're going to close out. I'm almost done. A good team leader may or may not be a prostate cancer survivor. It's the person who does all the things that I've just told you about. Maybe a woman. It may be a partner. It may be a family member or a good friend of a survivor. Or it may be someone who just loves to work on teams and just has a knack for teamwork. And they want to be known as a team leader. And this is one way that they can. One thing I want to say that we often make the mistake in medicine of not including patients on the team. And I think it's a huge mistake. And certainly the people in aviation who've taught us something called CRM, which is crew resource management. And this is a reminder from Dr. Niall Downey. That is Dr. Niall Downey. You'll see he's wearing a uniform there. He's probably the only commercial airline pilot on the planet who also happens to be a cardiothoracic surgeon. So he understands aviation and he understands the operating room. He said to me, when I'm flying, I can't see my engines from where I sit. A passenger might be able to report to me that there's something dripping out the bottom of the engine because he can't see it, but they can. And so in aviation, they have learned to include passengers just as they include air traffic controllers, and they include the grounds crew, and they include the cockpit, not just the cockpit crew, but the cabin crew. Everybody with skin in the game can report. And they function in a hierarchical system. The captain is still the captain, but Dr. Niall Downey, Captain Niall Downey says, I'd be a fool not to accept the wisdom of everybody who has skin in the game. So let me talk about patients and their partners as team members. Patients and families have often been the missing link in healthcare. They are absolutely essential to the mission of the Prostate Cancer Foundation of BC and all support groups across Canada. And so I'm going to ask you, who is on your team? I want you to reflect on that, think about it. It's certainly survivors, almost certainly spouses and other family members, other volunteers who just like volunteering, office administration staff, doctors, nurses, and other frontline healthcare workers, researchers, corporate sponsors. Is there anybody that I'm missing? The person who helps you make signs, the person who makes T-shirts for you, et cetera, et cetera. I want to just close out by reminding you some of the ways that the Prostate Cancer Foundation of BC can help. They can provide know-how and tips on event planning and fundraising, national and provincial experts and researchers on emerging and promising treatments. What you heard today, support for hybrid meetings. Didn't know they did that. Now I do. And remember, when I was trying to look after my sister, there were a million things I didn't know about providing care for her and managing her finances that I know now, and now I'm a resource. Support hacks. I learned about personal support worker hacks and home care hacks that I now share with other people. Speakers for events, insurance that's provided through the foundation, peer support from survivors and spouses on everything from incontinence to sex. I just want to summarize with some team basics. If you're just starting a support group, or if it's a well-established support group, do you have team goals? Have you gathered everybody together? Do you even know what they are? Have you had a hand in developing them? What's your mission? Has everyone had a say in establishing those goals? These are some of the goals here: fundraising, service goals, research priorities, media recognition, public or government advocacy. The important thing to remember is that you have your personal reasons for wanting to be involved, whatever they are: emotional, maybe reputational, maybe because you want to make sure that nobody else has to go through the same muddle that you went through at the same time. The important thing to remember is that you're allowed to have your goals, but you want to be aware of team goals. And sometimes what we think of as win-lose, like if the team wins, I lose, is actually a win-win. If I sacrifice my goals for the goal of the team, but the team wins, so I've won. That's another way of looking at it. The other thing I want to mention about teamwork that groups don't have, groups of individuals don't have. When you have a team, you have the possibility of shared joy. Remember, I told you that in healthcare, burnout rates are at 50% and climbing. When was the last time you said together, "We did it"? Well, to say we did it, you have to have a we, you have to know why we're all together, and you have to have exceeded your expectations as a we. So you've got a lot of work to do if you haven't had that. But I think you have the opportunity through some high profile, high impact events, for instance. You have a chance to have that sense of exhilaration, but it doesn't have to be that way. It might be that you motivate somebody, you help somebody who was in a total muddle, and now they're on the right path, and you can say, "We did it" as a team. So what can you do today? Just to summarize, shift from no or yes but, or no to yes and. Praise everyone for their superpower. Learn everybody's superpower on the team. Practice visual thinking strategies. What do you see about the situation? What do you see that makes you say that? What more can we find? And help your teammates and make them look good. It's been a pleasure speaking with you. This is a really auspicious occasion, and I wish you all the best of success as you move forward with your support groups right across Canada. Thank you.
Thank you, Dr. Goldman. That was great. Dr. Goldman's offered to answer a few questions, so I think we're probably going to try and do it through chat. So rather than have 100 people raising their hands and asking questions, so if you could please direct your questions via chat.
And I'm going to open up my chat so I can see them. Okay.
You getting any?
Not yet, but if you guys on the panel want to ask, Rochelle, if you want to ask, Maya, if you want to ask, go ahead.
Uh-oh, you're putting me on the spot.
I have a question. How do if you are in a situation as a support group where you've only had one leader for a long, long time, how do you switch gears and sort of get this teamwork thing started?
Well, let me ask the question back. Who else is on the team? So I think you want to start taking stock of who else you have. So that's something that's a really important thing to do. And I get asked a lot, what do I do if I've got a team member who's kind of command and control? You can be, I think that for every good leader, there are followers. And the first thing that I would say is commit yourself to being a good follower. Pull the team member, the team leader aside and say, how can I help you? How can I make you look good? How can I and do it in a supportive way? Certainly, the other thing that you can do is, you can't brush aside another leader, but what you can do is you can practice the power of teamwork. You can offer to be that person who talks about team goals. Why are we all here? Practice visual thinking strategies. Here's what else I see. Even if you're not prompted, what more can we find? Here's what else I see. So that's something that you can do. And you can show that person the existing leader, some of the principles of the power of teamwork, and don't underestimate them. They might be looking, they might be feeling a bit stale themselves, and they might be looking for some new ways of getting, they may be frustrated themselves. They might be starting to feel a little burnt out, that they feel as if they have to do too much of the work, too much of the thinking work, and they're looking for opportunities to share the load. Remember, the power of teamwork is not something that needs to be forced on people. If it really happens, people love it because they have less work to do. I don't have to make every diagnosis. I don't have to know everything. I don't have to know how to set everything up. I'm going to get prompted by people who want to help me because we want to function better. You see what I mean? Like it happens organically if people understand the benefits of the power of teamwork.
I have a question. What is the biggest learning or takeaway from Joanne's situation in regard to teamwork that you can share with us? Like, what's the number one thing that changed for you after her situation?
There's actually a million. I mean, there's really tens of things, but the most important thing, I was researching and writing the power of teamwork as all of this was happening, as I was at my least powerful, my most powerless. When I wasn't the actual power of attorney, when the bank wouldn't talk to me because I didn't have standing. And as I was writing chapter upon chapter upon chapter, every night I'd go for a walk with my partner, Tamara. And at one point, there was one day, I was telling her what was in the book. And I realized, I said to Tamara, you know what? I'm living the power of teamwork with my sister. I realized that, like, in my worst, scariest moments, when the tension would gather in my diaphragm, when I'd feel the most tense, I'd be thinking I have to solve every problem by myself, and I don't. So embracing the power of teamwork saved me. It's not lip service. It saved me. And it changed, it meant that from that point onward, I was no longer trying to solve every problem by myself. I'm much better at delegating than I used to be. Maybe that's what you'll take out as the most important lesson. I learned to delegate.
Yeah.
And I call it embracing the power of teamwork. But whenever I have a question, I ask it. I put the wisdom out there. I'll give you a perfect example of that. Recently, when my sister was hospitalized, I was going through the very difficult decision: do we continue active treatment or do we move to compassionate care? And instead of, in my old self, I would have felt as if I would have talked to my partner, Tamara. I would have tried to figure out what my sister would have wanted. But one of the things I did almost instinctively, which was very different, was I'm on a text chat called Joanne's Team. We call it Joanne's Team with her friends. And I asked my sister's friends, what do you think she would have wanted? She would want. Would she want to continue with active treatment like IV antibiotics for aspiration pneumonia, aggressive suction? What would she want? And they helped me come to a new solution. And then later I asked, okay, if we're going to start feeding her because we can't just let her starve to death, would she tolerate risk feeding? Would she accept the idea that in return for having food, being able to enjoy the taste of food, that there was a risk that she would aspirate? And they gave me answers. They knew Joanne better than I did in many respects, or they knew sides of her that I didn't know as well. So I would say that it's asking for the wisdom of the team instead of trying to figure it all out by myself was the most important lesson that I learned from her.
That's perfect. Thank you. So we have a couple of questions in the chat from Francois. At some point during my treatment, my oncologist asked me to be part of the team, but when I suggested to include a naturopath in our team, it was brushed away. Who gets to decide who the team members are?
Oh my God. Oh my God. That's in my heart, it's, there's a big difference between a doctor giving advice, which I think should be evidence-based. And if there isn't a lot of evidence for it, then they shouldn't be, they need to be offering evidence-based advice. But I think there's a world of difference between that and telling a person, telling a patient or a recovering patient that, patient recovering from prostate cancer, that a naturopath can't be part of the team. Because, that means that they're summarily dismissing not only the naturopath's advice, but they're also summarily dismissing the patient's desires. The patient wants, I would say, what do you see that, I would practice visual thinking strategies in that if I were the team leader, and I'd say, what do you see that makes you say that? And remember, yes, and not yes, but there's no evidence for that. But there's no evidence for that. No, I would accept it. And I would be asking questions like, what would it mean to you to have a naturopath on the team or a naturopathic doctor on the team? And we would come to a modus vivendi. I can tell you, you can tell me more, and I can ask you about prostate cancer survivorship. Do the principles of survivorship involve dismissing alternative treatments, complementary alternative medicine? And the answer is no, it isn't. As long as it's not harmful, as long as it's not actively harmful to the patient or drains them of their life savings, then I would certainly have no problems with it. But you don't summarily dismiss people on the team. And I could say to you that you need is it Francois, that you need another, you need to find another oncologist, which is a very, very difficult thing to do. But this is, and I empathize with you because I've certainly heard this before. But I think that person should be a member of the team, and no one person is taking control of the team. Otherwise, it's not a team. It's just it's a hierarchy.
Thank you. Oh, no, wrong one. Okay, what are your thoughts on getting to know what your fellow teammates' strengths are?
Well, first of all, you got to get to know them. And one of the things that you can do right now, and I'm conscious of time, so the short answer to the question is introduce yourselves to one another. And make it fun, make it a joke. Go in one day and have those sticky label name badges. Hi, my name is, and reintroduce yourselves to one another. And then the second thing, if you're an established group, have each member of the team name the superpower of somebody else on the team, not themselves, because that's self-promotion. When you name the super, because everybody knows what everybody does well on the team, if they think about it in those terms. And when it comes from another member of the team instead of yourself, it often has more power over the rest of the group. So I would do that. But certainly, the only way you're going to get to know that is by getting to know the members of the team. You want to know their frustrations. You want to know what gives them joy. There's a good chance that what gives them joy and pleasure in life is probably something that's attached to what they do really, really well. Those are just some suggestions.
Thank you. So we're actually at time right now, but we do have 2 more questions. Do you want to go into the break with?
Absolutely.
Okay. Thank you. So any suggestions on how you would motivate members of the group to buy into the teamwork?
Yeah, I would make the value proposition with them that I had on a slide back there. By the way, you have my slide deck. You're certainly welcome to share it. So I'd be saying, what if I told you that there's a way that nobody here is going to feel as if they are overwhelmed, that you're going to benefit from group wisdom, that you'll have a group sense of exhilaration, that if you've found that the work is too hard to do because you end up doing it all by yourself, you will never have to do it all by yourself ever again. Would you like teamwork? Would you like to know how to do that? There you go. There you go. So that's that one. Let's hear the last question.
All right. And then could you speak to teamwork when offering advice at a support group meeting, given that attendees for the most part don't regularly work together?
Offering advice. What kind of advice?
Not medical advice. That's our number 1 rule.
Okay. And can you just give me a scenario in which that would be a challenge?
Winston, could you speak to that? Feel free to unmute. Oh. Okay. Well, I guess so. If we had a patient come in asking for help with a certain scenario, how could the attendees of the support group work together to answer that person's question? So if they were having incontinence issues or.
Okay, now I get it. So if you're looking, I think you're looking for a framework for doing it. So Winston, the framework would be, I would use the visual thinking strategies 3 questions. I'd start with, what do you see? Like, in other words, and adapt the questions, because that's looking at a work of art. So adapt the question to be, what's your take on the situation? Well, the first thing I would do is I would ask the person, I would gather more data. I'd ask them, what they're noticing, and asking for advice from the rest of the group. What's your take on what you've just heard? What do you see that makes you say that? Or what's your reasoning? And then what more can we find? And that way, what all you're trying to do is to create a safe space for everybody to say what they see.
Does that answer your question, Winston?
Yes. Sorry, I can't unmute.
Well, that's
No,
okay.
no, you're unmuted. Winston, we can hear you.
Oh yeah, it does answer my question. I know it's the biggest issue at support group meetings, how people who don't know each other can work together to give good advice. You have extroverts, you have introverts, you have people who tend to step into the medical sort of advice when they shouldn't, and how that team can work together in an optimum way when you don't know each other very well.
So Winston, so 2 things. They need to get to know one another. That means actually, and maybe, have coffee together, or refreshments, or, go to Tim's together, or like have some kind of an outing, go bowling together, whatever it is, so that you can begin to get to know each other. So you have to get to know each other. And then the second thing that you want to do is to create a safe space. Once you've done that, create a safe space where everybody feels comfortable speaking and nobody gets shouted down.
Okay.
Thank you, Dr. Goldman. Goldman, sorry. We are going to all take a break now. So everybody, you have 10 minutes. We're supposed to do 15, but we're going to do 10. And we'll be back with an interactive session with Sway Partners, where we'll be talking about leadership. And thank you again, Dr. Goldman. That was fantastic.
My pleasure.